Well, thanks folks for joining. I'm Stephen Schueller, and I'm going to be chairing and also serving as the discussant for our symposium today. And we have a set of really fantastic presenters. I'm really excited about this symposium. I will share my screen. So the topic of our symposium is transforming city and county behavioral health through technology. And as mentioned, we have a set of really fantastic presenters, and this symposium is based on a project that's going on currently in California called Help at Hand, which is a public-private partnership. And our symposium really represents the synergy that's going on in this public-private partnership. So we have the representation from the counties. Maria Marino is going to be presenting on some of the work that's going on in Riverside County as part of this project. We have Audrey Klein, who's the Senior Director of Clinical Design and Operations at MindStrong, which will be talking about MindStrong and some of the work that they're doing in Orange County as part of this project. And we have representatives from the UC Irvine evaluation team that will be presenting on some of the lessons learned as UC Irvine and UC San Diego are conducting an evaluation, a formative evaluation of this project. And so I think that the goal of the symposium is really to share some lessons learned about what's been going on in this project, and hopefully really show some of the challenges and opportunities that have come up as we really try to put technology into use in real world care settings to be able to have people benefit from them. So we have a series of 4 talks. Each presenter will present for about 12 to 15 minutes. We might have time for a question or two after that. I'll give some brief remarks and discussion, and then we'll have some time for some question and answers across the entire group. So feel free to use the question and answer box along the way if you have questions, and we'll try to see if we can get to those after each talk or in between. And with that, I will pass it over to our first speaker, which is Dara Sorkin from the University of California, Irvine.
Thank you so much, Stephen. Next slide, please. I just want to acknowledge my co-authors and the many collaborators that we have here at UC Irvine and at UC San Diego. So back in October 2017, the Mental Health Services Oversight and Accountability Commission approved Kern County and Los Angeles County to initiate and form the foundation for the statewide innovative collaborative. And since then, 14 cities and counties have joined a collaborative which is designed to bring a set or a suite of mental health digital therapeutic technologies into the public mental health system. And this program really intends to understand how digital therapeutics fit within the public mental health system of care. And in addition, Help at Hand, as this collaborative has come to be known, also involves an effort to integrate peers or people with lived experience throughout the program. Next slide, please. So there are a number of technologies that are being implemented throughout these 14 cities and counties, and we're going to be talking about some of these today throughout the program. But there's a wide range of digital mental health therapeutics, things that focus on meditation and mindfulness, all the way to programs that provide virtual support and also cognitive behavioral therapies, just to name a few, including peer support. So we'll talk a little bit more about that as we move forward. Next slide, please. There are 5 primary objectives that are associated with this program that are shared across the cities and counties. 1, to detect and acknowledge mental health systems sooner. 2, to reduce stigma associated with mental illness by promoting mental wellness. 3, to increase access to appropriate levels of care. 4, to increase purpose, belonging, and social connectedness. And then finally, to analyze and collect data to improve mental health needs assessment and service delivery. Next slide, please. So there's a wide variety of stages that different counties are in. Some are still planning on implementing new products into their system. Others are fully implemented, and I'm going to give you a flavor of those in the next couple of slides. Next slide, please. So to give you a sense of the evaluation, we are using both the CFER implementation model as well as the REAIM model to help us organize how we think about looking at the impact of Help at Hand. And we take the view of considering everything from system and county level facilitators and barriers that might influence implementation to the experience of the user or the consumer or the patient or the client. We use a number of different terms to think about who is our target audience member. We think about the technology itself, its usability, its accessibility, and then finally we think about the outcomes for the innovation. Next slide, please. So here are just some 3 examples of the kinds of implementations that are going on across the collaborative. There are lots more that we could talk about, and you're going to get to hear in depth both from MindStrong, which is one of the technologies that's being implemented on this project, as well as from Riverside County, who is one of our most active counties in the Help at Hand collaborative. So next slide, please. Okay, so one project, just to give you a flavor, this is a project that was completed in Marin County. It was a pilot study of MyStrength. The focus and the target audience for Marin County was to work with older adults. They were primarily working with isolated older adults, and they really hoped to include both English and Spanish-speaking older adults. As a pilot, the sample size was intended to recruit about 30 older adults. And in addition to providing free access to MyStrength, Marin also provided all participants with the hardware to be able to access the program. They also they hired nurse interns and promotores to send people to the homes of the participants, and there they supported them with providing digital literacy training, including how do you get onto the app, how do you safely use technology, and then provided access to MyStrength for about a 12-week period. The evaluation included pre and post surveys of the respondents across the process. So looking not only at how older adults and some of the barriers around accessing MyStrength, but also how they experience the digital literacy training. We also administered what we're able to access within app data from MyStrength to be able to look at what we consider to be sort of objective data around how older adults use the product. We also were able to look at, collect data around the implementation and the experience of what that was like for the various different stakeholders who were implementing the program, including the administration, the tech leads, the peers that and the nurse interns supporting the older adults and the promotores as well. So we were able to have a very in-depth look at the experiences of both participants and implementers in the program. So this is one kind of example. Next slide, please. A different kind of example, and again, Dr. Klein will be talking a lot more about the MindStrong product itself, was an implementation of the MindStrong product in Orange County. Here, the focus was working with patients actually being treated in a large healthcare setting. So a different, an audience, a different clinical audience. And in this project, implementation, we were looking not only at factors that influence adoption of and use of MindStrong, but also what are some of the barriers that people experience, and why do people choose not to adopt a product like MindStrong? The sample size here is actually now currently up to over 300 with plans to possibly expand. I'm going to leave the description of the program to MindStrong, but here again, the evaluation plan included both consideration of the experience of the participants as well as the implementers, and included a series of pre and post surveys, as well as collection of demographic variables, surveys administered over the phone. And here we again have access to within app data to help us give a sense of some of the more objective use of the product. We also, unlike some of the other implementations, we also have the ability to integrate with the electronic medical record and include some analysis of that data. As well, we also have access to to the implementation side of the data collection, interviewing and surveying tech leads, providers, and administrators. Next slide, please. Whoops, we skipped one, but there we go. And then finally, a third kind of really different implementation is the Headspace Rapid Response implementation. And this involves the 5 different counties who are implementing Headspace and providing it to their general population. And in this implementation, we have the option of sending a survey to participants with a core set of questions. We don't have any access to any app data, but what's great about this is that we do have the ability to integrate the data collection across 5 counties. So that's just a flavor of some of the work, next slide, going on in the project. And if you'd like to see any of our reports, we produce a lot of them. You can go to this link and find access to all of the reports. So thank you, Dr. Schueller.
Fantastic. Thank you, Dr. Sorkin. We have time for 1 or 2 questions. If there's any questions from the audience, please feel free to use the Q&A box.
No questions yet.
I can pose a question for you before we move on. You talked about a range of different products. Can you talk a little bit about how the counties have kind of settled on using such a diversity of different products in a sort of collaborative project like this?
So initially there were two products that were the focus of that were really made readily available to the counties. But from that, the counties identified a lot of diverse needs and went out to reach for different products that they thought would be appropriate. A lot of this work is driven by peers who help to find and vet and test different kinds of products to see what's going to be most useful for their counties. So that's kind of a brief overview, and we can talk more about it if there's time.
Fantastic, thank you. And yes, we'll have some of our other presenters talking about specific products, as well as the county view that will be also talking about some of the work that Riverside's been doing specifically. So thank you so much for kicking us off. With that, I will pass it over to our next presenter, who is Audrey Klein from Mindstrong, who will be talking about technology-enabled care for individuals living with serious mental illness.
Excellent. Thank you so much, Stephen, and welcome everyone. I am very excited to talk about a partnership between Mindstrong and Orange County that has been really going on for several years. The county, similar to many counties and places across the country, has a need to serve residents that frankly have very serious mental health issues that are underserved and have a very difficult time accessing services. So we're very happy to be a part of that partnership. And I really wanted to focus my presentation on Mindstrong's approach, especially as it relates to technology, so people can really understand the clinical offering that we are using with the county and their residents, and also, most importantly, related to the theme of this summit, how technology is really embedded in our entire model. So moving to the next slide, as Stephen said, I lead the clinical design team and operations team at Mindstrong. We are a hybrid company, so we are a telehealth mental health provider that focuses on the whole spectrum of mental illness, but also really focus on folks with SMI, with serious mental illness. And we also have a tech part of our company, and our overall goal is to build out the best components of care delivery and evidence-based practice in mental health and merge them very intelligently in a very engaging way to reach our patients, who we call members. So I'll move to the next slide. So this is a depiction of our model at the broadest level. So on the left-hand side is our mission. So we strive to empower people, all people with mental health issues, but particularly those with SMI, What is listed in the latter half of the mission statement is how we do that. And it's really in two very large ways. First, we used advanced clinical care. So this is referring to our in-house multidisciplinary care team that I'll talk about more in a little bit, that leverages a number of tools and evidence-based practices to treat mental health and SDOH, or social determinants of health needs. Then the second component is to give members access to health tools. And those health tools are in our platform. There are a number of them relating to analytics that are powered by our platform, as well as tools and resources and support that members can always access in our mobile app. I want to direct folks to the arrow because it's very intentional. So everything that we do in our solution is aimed at the end of that arrow, right? That's our end result, to deliver exceptional clinical outcomes and help members at scale. So earlier in the arrow, we're really calling out the three elements of our approach that we believe help us do that. So the first is engaged access. So speedy time to care, getting members who are enrolling in our services to appointments very quickly, delivering that care in a virtual, very easily accessible way, but also doing it at high quality, because we do believe that quality care and care that is very personalized is also engaging. So we really focus on engaged access. Moving to the next components, we do measurement-based care, and it's the focus of our approach, and it's embedded at all phases of our model. So the two call outs under measurement on the slide are, we collect a number of active data points through clinical surveys and other patient-completed assessments like the DSM Level 1 cutting symptom measure. We use PROMIS L2 measures from the NIH to get more in-depth reads on clinical symptoms for people that screen high on those symptoms on the DSM Level 1. We also employ provider assessments where we use the CGI, if folks are familiar with that, to have our providers also give information and ratings on how the member is progressing in care. And then the last element is adaptable care. So you're going to hear a lot more in a minute or two about how we're using MBC and our technology to really personalize care for each member in a very data-driven way. So this next screen is a little bit busy, but I wanted to give everybody a sense of what our two users from a tech experience are experiencing. So the first thing shown here is a screen from the member app that's showing our urgent session functionality. So one of the things that we strive for is to connect members via the app to our care team when they're immediately in crisis. So the flow that you're seeing on that screen is our urgent support flow that is used to connect members at high risk very quickly to their MindStrong care team. The next mock is also an app flow where, so some of our members that don't access our care through partnerships with counties or through contracts with our insurance payers, sometimes members find us just on the internet and they go to our website and they want to enroll in services. The flow that you're seeing in this second sequence is the member going through the app and actually hitting the home screen, onboarding via the app. And then the screen you're seeing now is showing how they actually can self-schedule with a member of our care team. So they can schedule with therapy, psychiatry, a care partner. Once they do that, they can actually go through another flow in the app that's going to collect their insurance information. And once that's entered, our member operations team at MindStrong will chase that info and do that insurance verification to get them scheduled for a session. So we really do focus on quick access, full acuity, and again, specialized in SMI. The next thing you're seeing is actually screenshots of our other tool in our platform, which is our clinician provider platform. So these are just examples of screens in our provider platform that allow them to view member information, treat members, view information very easily before a session. Apologize for the font on there. I know it's really, really small, but these are screens that show schedules, appointments for that day. And then critically on the right, there's graphs that highlight recent member reports of clinical survey results and surfacing those folks to the clinician for follow-up. The next screen is also in the member app, and this is just showing some functionality within the app that arms members with the ability to complete mood assessments, clinical assessments, but also an ability to monitor and track and visualize the data so they can see their trends over time, which is again part of our MBC approach. And then the next image is just to give you a sense of the telehealth sessions with our therapy and our care partner teams via Zoom, which can be either via audio or via video. So I just want to be mindful of time. This slide is very dense in information, but I do want to make a few call outs. So this is really showing MindStrong's care ecosystem and our multidisciplinary teams and what they do. The graphic is intended to convey a very close relationship and integrated relationship with our provider teams. So we have psychiatry teams on top that do, psych evals, consultations, med management, all at a customized frequency that's appropriate for each member. Our therapy team consists of dozens of licensed clinical social workers, LMFTs, LPCs, that provide evidence-based therapy around mental health issues for our members. Very recently, MindStrong's applied science team that does a lot of data science pursuits for us recently built out a predictive model that we call a session optimization dashboard that actually analyzes past member data, relates the types and frequency of sessions to the trajectory or change in their symptoms in the past. And then that model generates a recommended cadence and session type for the clinician to consider, and then shows what the predicted clinical symptom trajectory would be based on past data. So that's just a call out to our therapists being very willing to pilot novel tools that are developed by other cross-functional teams. Our care partners are very critical to our model. They employ a health coaching role. They focus on SDOH and problem solving, but they are also our focal case managers for providing all of the care coordination and case management that goes into our approach. And then finally, at the bottom is another call out to some always on services and features that are accessible to members 24/7, right? Again, with access in mind. So I mentioned care coordination. There's passive monitoring that takes place both within the app as well as with the use of the app, which I'll get into in a little bit. The app has curated or recommended content that gets surfaced to members. We have health assessments through the app that can be completed on demand, as well as our administrative support through our member operations front-end team. Want to spend just a minute or two on onboarding and intake. So there's this slide, and then the second slide is another version of this. This is a way that MindStrong partners with a variety of organizations to identify and then get folks into our system and begin treating them. So this is the partnership example. So this would be applicable to our Orange County partnership as well. In this flow, we get a referral that is sent directly to us from the organization. Our member operations team then reaches out to the member to enroll them in the app and get their first appointment scheduled for them. We aim to get that done very quickly. The note here with our member operations team is that often our members sometimes have trouble like with the technology, particularly at first, just like, what do I do and how can I understand the app flow a little bit better? So our member operations team is designed to be high touch and actually get on a Zoom with the member and screen share and walk them through the enrollment process to make sure that they're successfully enrolled and scheduled. So those are the steps there. Once they're scheduled, they see a therapist for an initial intake, and then that evaluation will be used in collaboration with the member and the therapist to create their care plan. The next path very quickly is our direct to consumer path. So I mentioned this earlier, and this is really where people are able, they're not necessarily referred through an organization, but they're really able to self-enroll. So all of that takes place via the app. They're able to schedule. A member ops representative confirms insurance behind the scenes and some other things. And then the member gets their clinical intake and begins to work with our providers for treatment. This is just another call out at a high level to our measurement-based care approach. Again, we have several inputs along the way for MBC: passive data, clinician reported data, and member data. This is a very specific implementation of MBC that we very recently designed and implemented. It's a key ingredient of our MBC approach, and it's very goal driven. So the member and the provider collaborate to create goals that are appropriate. Those goals are very much quantified in terms of symptom reduction. So for anxiety, for example, for depression, not only does the member take those surveys and they're used to inform care, but they partner to actually build and create goals and track them that are defined by them improving on their symptoms. So this allows continuous assessment of goal progress and symptom resolution and people getting better as support and treatment are tailored to those symptoms. So I won't go through all those bullets because I just pretty much explained the DECP approach. This is a depression example, and this is at the bottom an example of what a provider sees related to a data-empowered care plan goal for depression. So as you can see, the provider dashboard is showing in a very seamless way when were the last clinical assessments, what was the overall member rating. In the middle, there's where is the goal, you know, the target range versus the starting range. And then on the right, they're very much able to track very easily whether the goals are complete, if so, how many, and then the actions related to the care plan and the goal that are completed. So a really nice UI there for our providers to help facilitate those goals. I know I'm about at time, so I'm not going to spend a ton of time on this slide, but this again is the way that we love to think about our approach for mental health. We're absolutely virtual first with virtual care delivery, with elements that really focus on engagement and measurement, as well as personalized care and care coordination for whole person wraparound services. So very much appreciate everyone joining the presentation. And Stephen, I don't know if we have time for questions.
Yeah, we have time for maybe one question now, and then we can loop back at the end. So there's a question from an attendee. I'm curious to hear more about how the outreach happens. How do you make the county aware that these services are available? And do you find that certain demographics are more likely to participate or more successful than others? So you talked a little bit about the onboarding after this question was asked, but would love if you could talk a little bit maybe to any findings or thinkings or thoughts around demographics who are more likely to participate, more likely to benefit, things that you guys have noticed in terms of who this type of service and this type of care might be most appropriate for.
Yeah, and Stephen, I might kick that one to Dara if she doesn't mind, because Irvine has done a lot of analyses on the demographics of folks that end up enrolling in care. So I can tell you that we do have some trends around. So folks that are we typically see older members for our broader member population in their 40s and 50s, but the county tends to have younger folks from Orange County. And we really think that that's because of the technology base of what we offer in that demographic, really not just being comfortable with technology, but almost expecting it as part of care. And also the ability to kind of self-drive some of the care that they're receiving. We get referrals directly through the county, and we have a partnership with folks through Orange County and through Irvine, where we're all meeting as a project team every couple of weeks to really talk about the program. How is it going? We read out the data, we look for engagement or upticks in outreach, and then we tweak, we figure out whether it's on their end, whether it's on our end, like with our member operations team. So this is accomplished through a very cross-organizational group that works very closely together and almost does like our own version of MBC or project management as we go along and evolve accordingly.
Awesome, thanks. Dara, do you want to add any quick words here about sort of thoughts around, who these, for MindStrong specifically, and thinking about what we've learned so far, if you have any sort of comments you want to make about, who seems to be engaging, who seems to be the ones who might be benefiting?
So what we see, exactly that Andrew was saying, that in this implementation, about half of the folks who are participating are under the age of 40. So it's a younger sample. It's predominantly female. Over 60% female. A high percentage of Latino, Hispanic folks using the product. I think in part because of the way that people were recruited to use the product. And what we're seeing preliminarily is actually sort of equal use of the product across age group. Not a lot of evidence for any kind of particular age difference, that the product being better or more useful for a particular age group. We're seeing sort of the people, generally the people who are using the product are, those are the folks that we're seeing the conferred benefit from it. But it's all preliminary.
Great, thank you. Well, there's a couple other questions, and I think we'll be able to come back to them at the end of the presentation, or the end of the session, when we have some sort of extended question and answering time. But I'd like to actually continue to move us along. And our next presenter is Maria Marta Marino from Riverside County, who's going to be talking about transforming emotional wellness across Riverside County and beyond with technology.
Thank you so much. Thank you for having me here today. I'm going to go ahead and share my screen. Let's see here. Okay. So first of all, let me thank you for the opportunity to share and present what our Help a Hand program is doing in Riverside County. My name is Maria Marta Moreno. I'm the tech lead and program manager of this Help a Hand program in Riverside. And basically, as part of the statewide collaborative, our goals are to introduce digital technology to improve the emotional wellness of our communities. And what we are doing in Riverside County, basically we are creating these outreach and engagement type of innovations. We do want to use technology in a way so we can reach specific communities that we will not be able to reach otherwise. We are testing out new digital technologies and working with other counties as well to expand our learnings. We are also, as key component of this project and efforts, we are using a cultural competency as a key component of all our implementations. Let's see, I'm going to focus today on 3 main implementations in our county, but this presentation, you have access to it. We have other efforts and projects that are work in progress, but today I'm going to focus just on 3 areas, 3 implementations. One of them is the Take My Hand Live Peer Chat. This particular project is a chat interface. It's a peer-to-peer live chat interface, and basically we use our peer workforce that have stories of recovery. They are operating this chat. The community, when they reach to our Take My Hand Live Peer Chat, they get connected with a live person that is peer certified, and that they can walk them through their own recovery, you know? So, and then basically our goals are to help our visitors, our website visitors, build resilience when life is difficult. This was mainly very important during the pandemic. During the COVID pandemic, our county was able to do a rapid implementation of this innovation. And also our department was also very excited that we were able to continue having our peer staff provide the service that they provide. Because with the COVID pandemic, you couldn't do an in-person service. But with Take My Hand, they were able to continue working via the chat interface. One of the personal stories that I wanted to quickly share is that when somebody is having a mental health symptom and they are unable to or don't want to travel to a clinic, this particular service is a lifeline for them because they can quickly reach somebody, and they can quickly reach somebody that can talk to them and help them with their symptoms they might be having. So on this particular project, we have done, we have partnered with our Dream Site marketing vendor to do different social media posts so we can reach the community of focus that we have in our state plan. Recently, I wanted to just share that we are having our Veterans event coming up and our Halloween. So we are trying to reach people based on the different activities that are going on for that particular month. We have different infographics that are with the effort to reach our very diverse community. And let's see here, we have different outreach events in schools, in colleges, in county events, community events. And then we have different presentations also that we are basically invited to do presentations. We are basically communicating that this service is available. It's a chat that is free, it's anonymous. And then we have different testimonies of how the people that take use the service, how they feel after they complete the chat. So let's see here. We do have a data infographic that our evaluation team was able to create. And just wanted to point out here that one of the highlights in the history of how the county serves the community is that historically, our Asian Pacific community, we have always have a 1.7%, 2% of being able to serve that community. But with Take My Hand, our percent is 30%. And also the same thing, we have a good percent for the American Indian community. So that's one of the highlights that I wanted to share. We do use Google Ads, and we are tracking to make sure that we reach our rural areas. So we have a map that keeps track of that. We upload our reports, and we're tracking to make sure that we make enforce and promote those efforts in those rural areas. And this is just some of the statistics for 2022 on the Google Ads, the number of impressions and the clicks to the website. And this is one of those digital advertisements. We have also another aspect of this is because we do have a lot of traffic to our website. We want to make sure that we promote stories of recoveries. And our Moonbat navigates people that visit the website with different videos that our peers are basically sharing their recovery stories. And these are our digital ads. And we have had a heavy campaign in bus advertisement in the desert and bus shelter in the rural areas. So that's one of our goals, to reach out the desert. The county is a very geographic, large county, and it's difficult to reach some of those areas. So that's why we put a great effort in this marketing campaign. We have radio in one of the rural areas in ANSA, in the ANSA community. Let me see if you can hear it.
KOYT-ACB is made possible in part by generous donations from organizations like Take My Hand Live Peer Chat. It's a help at hand resource available in Riverside County. It can be used to quickly connect you to chat with someone who really cares about any feelings or experiences you may be facing. Peers are available 8 a.m. to 5 p.m. 7 days a week. Chat with a peer to get help and resources for your mental wellness. The website address is takemyhand.co.
And in the interest of time, I'm going to jump to our A4I innovation. A4I, well, we have our kiosk technology. I was almost going to skip that. The purpose of this deployment of kiosk technology is so we can make this live peer chat available in those county clinics. We realize that a lot of people don't have data. A lot of people don't have internet. So the people that we serve can still use this resource in the clinics, in the outpatient clinics. So we had a phase 1 implementation of 32 kiosks and 8 large kiosks. And you can read a little more about those. Let's see here, our app, A4I app. This app is basically specifically for individuals or persons that are experiencing or have a diagnosis of schizophrenia or psychosis type of diagnosis. One of the key aspects of this app is that it has a sound detector that tells the person whether or not that they are having an auditory hallucination or not, or if it's an environment sound. In one of our interviews of the participants that completed the graduation of this pilot, we had some participants that actually told us that they were using the phone to have it during the night. and testing their auditory symptoms and checking and being able to sleep better because of that. Because the phone will tell them, oh no, that's an environmental sound, or that's not an environmental sound. So they will know, oh, okay. So nobody is out there. I'm not in danger, you know. We distributed phones for those participants that are using our A4I app. And then let me show you this quick video.
Managing the symptoms of schizophrenia felt tough and sometimes lonely, but now things are looking up thanks to the new app for independence. A4I gives me access to tons of great tools to help me live my best life. I love the toolkit. I can connect with my care team by writing notes, like talking about my goals, monitor my sleep patterns, save motivational images and reminders to keep me centered, and see wellness reports to make sure I'm on top of my health and see how I'm doing over time. The ambient noise detection feature comes in handy when I want to distinguish between sounds in my environment and makes me feel at ease again. Throughout the day, I check into the newsfeed to connect with my peers and see any new content that's been posted by others in my community. And none of my information is tracked, so I feel assured knowing my identity is safe. Setting reminders is a breeze. It makes it easy to remember my medication or attend an appointment or social event. I can even choose to be notified or get a text message. That makes it even easier to stay on top of my experience. With the A4I app, I'm starting to feel in control of my emotional wellness again. I love knowing that the A4I app is always there for me when I need it and ready to connect to care.
So with that, I'm going to close, but I wanted to show you that we have so much more information in this presentation and that you can access it just by scanning the QR code at the end. Thank you so much.
Thanks, Maria Marta. I think we have time maybe for one question. There's been a couple of them, so we'll save some of these for the end as well. But can you talk a little bit about what happens when you find participants who are in crisis? So like, what are some of the crisis support plans that you guys have to support technologies that you're using as part of your Help at Hand project?
Yes, we do have care team members that are also participating in this pilot. So for instance, let me go back here. When somebody identifies a crisis, there is communication among the team to reach out to that individual and actually support them in getting the help they need. We have had different stories. Recently, and that story is not ready for publication, but it's going to be published where the life of one person was actually saved because of this. We have a very active peer team that monitors the news feed on a daily basis. And then also our care team are checking the dashboard and looking at the journal entries, and based on that, they can quickly, basically it tells them, we have a story here, it tells them how to address the next visit and what type of things may be happening with that individual, whether or not they may need to look at the medications again, or if they need to actually get taken for a hospitalization.
Great, thanks. And I'll just note like one thing I thought was so impressive in your presentation, and I get to live this as being a member of the evaluation team on this project too, is just the careful consideration you all think about in Riverside of like really reaching different populations. So I love the portion talking about the work you've been doing with the deaf and hard of hearing community. And I know we as a team, put out a paper together based on some of that work. So I think it's really just such great work, and There's some other questions that are here, but we can return to some of those questions at the end because I think it goes across some of the presentations. But I want to move us along and actually have our last presentation as part of the symposium, which is Judith Bourgeot and Elizabeth Ike, who will be presenting on user engagement with mental health technologies. And both Dr. Bourgeot and Dr. Ike are members of the evaluation team here at UCI and UC San Diego.
Thanks, Stephen. Hi, everyone. I'm Judith Borgouts. I'm a researcher on the evaluation team here at UC Irvine, and I'm co-presenting today with Liz Ike. And we're really excited to talk about some of the user evaluation work that we've been involved in as part of the Help at Hand project. First off, Liz will give a high-level overview of the type of studies and the range of studies that we've done throughout the project and what were some of the things that we looked at. And then I will give examples of 2 specific studies that we did to illustrate what some of the studies look like. So Liz, I will pass it on to you.
Thanks so much, Judith. So I just want to mention that Judith and I work really closely together as part of the evaluation team for the Help at Hand project, focusing on the consumer experience evaluation components. But it's really important to mention that this is a monumental effort that's supported by our incredible consumer experience evaluation project manager, Cynthia De Leon, the rest of the evaluation team at UC Irvine and UC San Diego, as well as the counties, cities, peers, community members, and other folks who are involved in the Help at Hand project. So the consumer experience evaluation, our goals are really to understand the consumer's needs, their experiences with technology, as well as contextual factors that influence their perceptions of and engagement with various technologies. When we're talking about the consumer, what we really mean is anyone who the technology is intended for or we're trying to serve, or who could potentially use the technology or who is actively using the technology. One of our goals really is to inform a person-first approach to understanding which technologies might be suitable for whom and when. I think this is why it's important that, Stephen, you mentioned from the last presentation in Riverside, really aligning technologies with the various populations. And so we broadly bucketed the types of consumer evaluation efforts that we've done into 3 categories. So the first is the needs assessments, which really seek to understand the mental health and wellness needs of a specific community, as well as the role of technologies that they might or might not play in supporting those needs. Needs assessments also include understanding the consumer's broader context to really better align potential support efforts with their needs and lifestyles. The second type of consumer experience evaluation that we participated in is the technology explorations. These are usually short-term experiences with technologies where a small group of consumers get to test out one or more technologies and share their experiences and opinions after being exposed to or interacting with those technologies for a limited period of time. And then third, we also have the technology evaluations. So the goal of technology evaluation is really to assess the consumer's experience with a specific technology, either over an extended period of time. So as Dara mentioned earlier, the Marin County pilot, or in real world implementation. So like the Headspace rapid response implementation. This could include measuring the impact on mental health symptoms, stigma, social connectedness. It also includes things like the usability or accessibility of the technology and how the technology fits or doesn't fit within consumers' lifestyles and more. Even within these buckets, you'll notice that we provided some examples of various methods and approaches that we use to gather relevant information. So for example, we've conducted needs assessments with community college students in LA County using randomized surveys, as well as needs assessments with the deaf and hard of hearing community in Riverside County, utilizing both focus groups and surveys. And Dr. Borgouts will focus on the latter later in the presentation. We've worked alongside counties and cities to support technology explorations as well, which include working with older adults, transitional age youth, and adults with mental illness. Many of these tech explorations included some exposure to technologies, then focus groups and surveys to assess their sort of initial reactions to engaging with those tools. And in the interest of time, we won't be diving deep into technology explorations, but happy to answer questions about those later on. And lastly, we've conducted multiple technology evaluations, including some with older adults in Marin County using MyStrength, as well as clients at UCI Psychiatry using MindStrong in Orange County, and broader implementation efforts such as the Headspace implementation across various counties and cities. So depending on the context, we've conducting longitudinal surveys, interviews with consumers, and also looking at data from the technologies themselves when available. You already heard a little bit about MindStrong, so Dr. Borghaus will focus on Headspace as an example case. Next slide, please. Thank you. So today you'll only get a snapshot of some of this work, but what we'd sort of like for you to take away from this at a high level is that the consumer evaluation is more than just the interaction with the technology. It includes consumer needs as well as their experience with the technology, which means understanding factors that can inform the selection and implementation strategies of a particular technology, as well as understanding its use and non-use and how people actually engage with the tool. So there are a range of findings from the Help at Hand project. There are some commonalities and some differences. Dr. Borghaus will explain some key findings that came out of the examples that she'll present today. Just keep in mind that these are only snapshots of the work that have been conducted, and thus all of the findings are not necessarily represented, but you will get a taste of some important considerations. So for instance, if you look at the left-hand side here in terms of the consumer needs before selecting a potential technology, we've assessed things like mental health needs. We've uncovered a variety of barriers to using technologies such as accessibility and language needs, stigma and perceptions of mental health, as well as facilitators, which can range from cost to privacy to impact on a device to connecting people through technology that share similar lived experiences. On the other side, on the right-hand side of the screen here, in terms of the consumer experience of a specific technology, we assess experiences and perceptions. Across technologies, we found many consumer participants often recommend the Help at Hand technologies that they're engaging with. However, even if many reported a technology was easy to use, there are some people who don't necessarily have adequate access to help and support to use the technology over an extended period of time. With this, digital literacy can also play a role in sort of comfort level with technology, depending on the specific community or the individual who is being served. Another important thing to note is that non-use of a technology, so even when people stop using a technology, it's not always an indicator that the technology is not working per se, although it can be. We've found that many reasons for people stopping use of a technology, while they range, oftentimes it's because people are using other mental health resources, and this was sort of one resource that they were trying to fit into their toolkit. So through the technology evaluations, participants have reported benefits to using these Help at Hand technologies. These vary depending on the population, technology, and context, but Dr. Borghaus will give an example in the two cases that she'll go over today. So I'll go ahead and turn it over to her.
Thanks, Liz. Yeah, so I'd first like to start by giving an example of a needs assessment we did. So as Dr. Schueller briefly mentioned, before our presentation, is one example of a needs assessment we did was a focus group that we did with Riverside County with 10 members of the deaf and hard of hearing community to understand their views on what are some of the mental health needs within the community and how a digital tool may address these needs. And what was really special about this study was that we were able to work closely with a local advocacy group called the Cody team, who not only shared their experience and gave their insight, but were also instrumental in helping us run and facilitate an online focus group discussion. So some of the things we found was that there was actually a range of linguistic needs. So they expressed that some community members might feel more comfortable with American Sign Language and want more support if a digital tool were to offer them mental health support, whereas others might have a preference for English. And even within those having a preference for English, there might be different literacy levels in terms of reading and understanding English. So rather than providing one or the other, they said it was really important to provide the user with options in how they would like to receive and communicate information through a digital tool. They also talked about various barriers that made it difficult for community members to currently use and access mental health resources. And a common barrier that multiple members expressed were that there was still stigma around seeking help for mental health. And they also highlighted that they might miss out on informal or incidental learning opportunities around the concept mental health in the same way that the hearing community may, so that there was an increased, a need for increased education around mental health. And a further barrier was that people were concerned if they were using a digital tool, that their data might not be private. Lastly, people also expressed that when thinking about a potential digital mental health tool, what would be important? And they expressed a range of things, but in particular, they said that it was important that community members were able to interact with the deaf worker directly, rather than, for example, having to go to an interpreter who had the sensitivity and also the same experience as them. So this was an example of like a smaller scale, more in-depth study we did to understand the needs of a specific community. The next example that we would like to highlight is an example of a larger scale technology evaluation that we did around Headspace. So as mentioned earlier in the session, in response to the global pandemic in 2020, several counties have begun offering Headspace for free to the general population as a mental health resource. And to better understand people's ongoing experience, we have been sending out surveys to anyone who signs up for Headspace through their county. And so far, we've been able to get responses of around 2,500 consumers. And data collection is still ongoing, but what a trend that we've been seeing so far is that the people who are using Headspace are overall positive about the technology itself. So we found that over 90% would recommend Headspace. They found Headspace easy to use and useful. And most of the reasons that people indicated for abandoning Headspace or like not using at all were that they already had other resources that they were using and they just wanted to try Headspace out. So this kind of indicates that abandonment might not be related to a negative experience with technology per se, and it might still be reaching the people who are in need of it. So taken together, and just to sum up, what are some of the high-level insights that we have learned and can take away from doing these user studies? And the first is to consider unique circumstances of a core audience. So as Dr. Eike mentioned at the start of the presentation, even though there are some like overarching trends, we found working with different populations that there are also some factors that were unique. So tailoring an implementation to the unique circumstances and context is key to improve product uptake and maintenance over time. Following up from that is it's important to consider like what are actually the factors that may influence user engagement. So consumers might find the technology itself great and easy to use, but there might be existing barriers that make it difficult for people to continue using the product. For example, people might not have the required support, so they might abandon an app if they're experiencing any technical issues. So it's important to like assess what level of support is needed, and when possible, provide those support to people to be able to use it. And lastly, we found it's not only important to look at user engagement and are people using it, yes or no, but look beyond that and explore like what are some of the reasons for abandoning it. So again, it might be related to the technology itself, but there might be wider contextual factors, or it might be people have gotten everything that they got from the app and or they're already using other resources that are helpful to them. So thank you so much for listening. That is all we had today. And for the sake of time, we kept our presentation quite high level, but we're happy to answer any questions that anyone has.
Great, thank you so much for that great presentation. There was a question in here that I think you touched on a little bit at the end, but maybe, and I'm sure other panelists would have some thoughts on this as well, and maybe we can loop back to this, but almost universally across mental health apps, engagement has been a problem. How do you grapple with that issue? So maybe just a couple more thoughts or points on the aspect of engagement.
Judith, I would actually like to pin this over to you, because not only have we kind of looked at this from the perspective of help at hand technologies, but Judith also first authored a paper looking across literature that helped inform a lot of the things that we considered when we evaluated a lot of these different tools. So Judith, I'd like to actually pin that first over to you.
Sure, thanks, Liz. Yeah, so what I found important is going back to that paper that Liz mentioned, is that there are several different kinds of factors that can influence whether users engage. So it can be related to the technology itself. It might be the wider implementation. Sometimes it might also be the user and like whether they are able to fit it into their daily life. People might also like have different reasons why they're using a technology. So for some technologies, they might want to use it every day. There might also be people who access it whenever they are in need of it, and when they're not in need of it, they don't use it. So non-engagement doesn't necessarily have to be a negative thing, but it's important to understand those wider contextual factors and if that's something that can be addressed.
Great, thanks. So I'm actually going to make a couple comments as the discussant, kind of going on some of my sort of reflections on the presentations that were here and some take-home points, and then we'll go back to some of the questions that were asked already, because I think that some of these really go across the panelists and across the presentations. And if you have more questions, feel free to continue to put them in the Q&A. But I just want to take a step back and contextualize all of this work that's going on, because I think that, you know, as I'm hearing this, I'm reminded about just how impressive and ambitious this project is. And I think that that ambition has really been made possible by some really unique circumstances in California that, for those of you who are not from California, you may not be totally aware of. And that years ago, California passed the Mental Health Service Act, which essentially put a tax on everyone who makes $1 million or more per year. Sometimes it's also referred to as the millionaire's tax, and they get taxed 1% of their income that goes to support mental health services. And you know, that in California, that actually tends to be quite a lot of money. Don't think I've tracked the most recent fiscal years, but in the previous fiscal years, it was just around $2 billion a year that was going into this fund as part of this. And those dollars are used to fund a variety of different things. They fund prevention and early intervention resources. They fund workforce education training. They fund full service partnerships, which are wraparound services for those with serious and persistent mental illness. And they can fund innovation projects. And so Help at Hand is one innovation project that is funded through those Mental Health Service Act, or as we call them in California, MHSA dollars. And it was a really, you know, I think it is a really ambitious project, because it's bringing different counties together to work together, which was an innovation in itself in doing this project and working across counties and doing things at the scale. And so I think that one of the things that, you know, this also just reminds me about is like the potential to really do innovative and interesting things with mental health services when there is buy-in, when there is support, and when there are resources that are being created by, you know, in this case, the state, and thinking about what might we do, you know, better in this country or in other places in terms of thinking about leveraging some resources for mental health support. I think some of the themes that I kind of heard across the different presentations, I think sort of really thinking about how technology is able to achieve the goal that I think we all want to sort of be thinking about in mental health service delivery, of getting the right care to the right person at the right time. And there's multiple different elements in terms of how we think about that. We can think about sort of accessibility, which includes both access, how do we just get more care out to more people? And I think that was talked about in some of the different presentations, as well as accessibility and making sure that the care that's getting out there is accessible to people from different, with different abilities. And so, you know, both the last presentation and Maria Marta's presentation also focused on some of the work with the deaf and hard of hearing community. And I think that although that's a promise of digital mental health, it's often something that's not considered and not thought about. If we look at these products as they've been deployed at large, they're often going to middle-aged white women. And I think that came up in, Dara's comment around some of the users of, MindStrong and the Orange County deployment specifically. So I think that we have to sort of think about how we reach populations that have been traditionally left out. How do we get more mental health services that men want to engage in? And how do we sort of get services that go out to sort of rural areas? And Maria Marta sort of mentioned in their project some of the marketing efforts to really think about getting to those rural parts of Riverside County. For those of you who don't know California that well, you might think about California as the big cities and the coasts. We have significant rural regions in California, so it's a big state with a lot of different needs. Another sort of overall thing is thinking about the efficiency of care. How do we get more care how do we get our providers and our care network we have the capacity to be able to support more people, because we don't have enough trained mental health professionals to provide care to those in need. We don't have professionals who reflect the background, the racial, ethnic background, the identity background, the linguistic background of folks who have need. And so I think we heard some different examples of ways in which efficiency of care might be able to be increased, such as MindStrong's use of these different technological features that can sort of identify the people most in need of care. Or thinking about sort of stepped care models, which is starting people with lower intensity treatment and moving them up when they have subsequent treatment. I think that the way that Maria Marta was talking about the Take My Hand project and being able to be sort of like a safety net level of support that's out there in the community to be able to provide some help and support for people. And I think that really links into the notion that we just heard from Dr. Ike and Dr. Burgos around having some people using these tools as a tool in their toolbox as they're exploring different mental health resources. So I think there are times in which we sort of present these technologies as instead of mental health care, which maybe in some instances where other services aren't available, that might be appropriate. But I think we also have to think about these as the yes and how these technologies are weaving into sort of a network of care that help meets the diverse needs of folks. And I think also trying to think about mental health, the efficacy of mental health services. How do we make better treatments that are more effective for those who are actually engaged in treatment? Because so often, even when people get into care, they fail to get high quality care. They fail to get care that actually reduces the symptoms and challenges and reasons that brought them into care. And so I think we heard some of the instances in which MindStrong is integrating different aspects of measurement-based care and sort of person-centered care in terms of really thinking about the goals that people have as they come into the program as ways maybe to sort of increase the efficacy of care. So I think as we sort of tackle the question of right care for right person at right time, we have to think about these sort of components of accessibility, efficiency, and efficacy. Another thing I want to note that kind of came up in the MindStrong presentation, but I think has been a lesson learned across this project is, although sometimes these technologies are posed as like light touch, low intensity interventions, in the onboarding sometimes there's need for high touch to get people engaged. And I think that was something we saw in the Marin pilot that Dr. Sorkin presented earlier, is that a lot of the effort that these supporters were doing was focused on actually getting people onboarded, getting the technical issues sorted out, getting people like using the technology. Once you can get people on board, they're often really likely to engage and really have a good experience. But getting people in there and getting them comfortable, I think, is something that is a serious concern. And I know a major part of this project, and you've heard this from different presenters, is really trying to build digital literacy skills for the individuals who are interacting with these technologies. I'll maybe make one more point before we open it up for other questions, but I just wanted to comment on this point that I think was really greatly illustrated by the last presentation, and goes back to this question that was raised by one of the audience members around the aspect of engagement. And I think engagement is a major challenge that we have to grapple with, but I think as noted, disengagement, when people stop using the product, is not always a bad thing. There's multiple reasons in why people might be doing that. And so I think we often have to think about, the term I use, I've stolen it from other areas, is happy abandonment, people who stop coming because they got what they needed from the program. And when we look at these large attrition or non-engagement curves, there's some population of people, it's not 0, it's not 100, I don't know what the percentage is, somewhere between there, who stopped using it because they've got what they need already. So I think that, the last presentation, Dr. Bourgeot and Dr. Ike, I think really sort of illustrated well that we need to be asking more nuanced questions than just, did this person stop using a product? We have to know why, we have to know how, we have to know what else they're using. And maybe if a person started using one of these products and that helped convince them to get other care, that's a win. But we often aren't able to track that. So I think one thing that's really great about this project and part of the evaluation is actually going back to those, the people who sort of were presented it and didn't adopt, or the people who started with it and stopped using it, to understand a little bit more about like why that is. So those are some of the comments I have. Maybe we can go back to some of the questions that were already raised. And I wanted to actually ask this question across the panelists, because I think this is a really great question. And I know that different people have grappled with this, but maybe I'll pose it to you first, Maria Marta, and then other people can jump in. Are there populations we're inadvertently excluding with these approaches? And the question asker brought up, aspects of poor internet access and low trust with technology, but I'm curious if you have any reflections or thoughts on who you think might be being left out currently, and what are some approaches or things we need to think about to sort of bring more people into the fold here?
Well, the main people that need the help, with our Department of Mental Health is serving a large population of homeless or people from the re-entry communities that may not have a phone with reliable data. So that's the reason why the kiosk deployment was a good approach to try to close those gaps. Having this kiosk available in the actual re-entry programs. New Life is one of them, and in the residential places as well. To allow for somebody who is actually in an inpatient facility, allow them to get that exposures to resources, to reduce stigma, to educational videos. They are right there, they're homeless, but they are being in the inpatient facility for 14 days. They have a kiosk, a large kiosk that they can browse and they can learn, and it gives them that opportunity to see the resources that are available. They can connect with a peer chat person from the small kiosk. Other than that, I just don't see how we can improve those gaps. Those gaps exist, and it's so much more bigger than what we can do. Other than I know our department got some other millions of grants and money to build new facilities, and the fact that we can put more kiosks in these facilities. On the facilities where these people are being housed now, that are not homeless anymore.
Thoughts from other presenters on, from your perspectives on the project, maybe populations or groups that are being left out, or how we sort of think about engaging or jumping in with other groups? Yeah, Dr. Ike.
Yeah, so I have some thoughts on this. I think from my perspective, this is also why, and I think this also, so two things. From my perspective, I think this relates a little bit to like the needs assessment work that we're doing, but is also related to another attendee's question about, at least from my perspective, on like advice that counties and cities can do or communities can do when they want to implement these types of tools. I think that's a related thing, because I think from my perspective, a small step, right, is really just talking with community, right? It's identifying potential populations and communities in which you actually want to serve and who might need the most support, and then building capacity and relationships with them to really understand what their needs are. And so sometimes that means really identifying that the technology that you thought you wanted to implement maybe isn't the answer because there are other barriers, and maybe there's another thing that you can do, such as like the kiosks, or maybe it's not technology at all. Maybe you need to start with, digital literacy programs or something so that you can build the capacity to eventually integrate technology within your sort of behavioral health or your community setting. We saw this a little bit in, for example, the Marin County pilot, in which it wasn't just a technology that they offered to older adults, but it was a more wraparound program where they had digital literacy efforts as part of this. They also, identified where internet access might be an issue and provide people with Wi-Fi where it's available, or where technology access might be an issue and provide people with tablets. So I think there is a way to try to understand those needs. Of course, it requires some flexibility, in sort of the planning and the way that resources are allocated.
Elizabeth, I love those points. And just to build on what you shared. So, and Stephen, you flagged this earlier, and it was such a great point, right? Like, we want technology to enhance care, right, in the ways that we're designing and hopefully implementing. But when that technology is a barrier or it isn't a fit for somebody, creating pathways for them to still receive care. So, and Maria touched on this too, right? Like, telehealth is very much like slightly mixed blessing, I guess, because it opens up accessibility to care, even like direct counseling and therapy and psychiatry to people that have barriers like transportation and living situations that aren't safe, where they just can't like get to regular appointments or go to bricks and mortar types of facilities. When you add on the fact that like your average clinic visit can be like 8 weeks out, that gap is very much realized with telehealth, but it brings other challenges, right, that have been discussed. What do people do, right, that don't have internet and that don't really want to use a smartphone for part of their therapy and aren't comfortable? So at MindStrong, we really don't want any of those experiences or situations in a member's life to prevent them from getting care if they want it. So like, our therapists will do phone calls with folks if members are like, oh, I don't want to do the survey in the app, I'm just not comfortable with that. Then they talk about it over a Zoom, and the therapist will pull up the survey in our provider portal and complete it with the members. So it's just important to have different pathways built into your model that can help accommodate folks that are not comfortable engaging with that technology. And it's just another way, frankly, to meet people where they are regarding accessing care.
Great, thanks. I'm going to kind of combine 2 questions here, and maybe Dara, start with you on this question. So there's 2 questions. One's about how are the approaches tailored to the demographics or tailored to different counties? And then there was another question that was on the sort of outcome measures for these initiatives, especially as they're sort of large initiatives across different counties that have some variance and some differences in. So could you talk a little bit about like how the counties are going about kind of coming up with whatever they're doing that's unique to their county, and how you sort of think about doing a large evaluation that has this sort of variance and differences across counties while trying to gather some overall conclusions?
Yeah, those are great questions. So the counties themselves work together in a collaborative capacity, but ultimately the counties take the initiatives and are tasked with identifying what products do they want to implement, and then what are their target audiences and how do they go about doing that. The project started with each county developing a plan, identifying, what were the areas of focus and who were those target audiences they wanted to try and target. And then where you get some real interesting and exciting working together is that as counties are learning about different products or different implementation strategies, they're sharing with each other in the form of there are bi-monthly meetings where the tech leads are getting together to talk about the learnings. There are opportunities where if one county, is learning about or trying to address a particular barrier, and they'll share that information with another county. So ultimately, though, the implementations and the technologies are very local. And because of that, you see a lot of variation across the state in terms of not only the products being chosen, but how they're being implemented, which creates opportunity and challenge for trying to understand then the impact of this collaborative across the state. And so for those of you, some joined the presentation late, there were 5 major outcomes that were agreed upon across the collaborative. And those major outcomes are in part what we tie the evaluation to. But we have to go deeper than that, because in some cases, the impact is maybe small in a pilot, and the goals might not be to ultimately bring about a change in mental health symptoms. The goal might actually be to understand the acceptability and feasibility of using this technology and this target audience. So there's been a lot of learning, not only in what products might make sense where, but really how do counties and cities work together? How do they vet technology? How do they share information? How do they even agree upon from the very outset, like what are the common goals? How are resources shared? And there's been a lot of learning, I think, on this project in those spaces as well.
We have about 2 minutes left. Does anyone else want to tackle anything, any add-ons to that, questions about thinking of the unique tailoring that's going on in each county, or how the evaluation is being able to balance sort of both the local and the collaborative needs that are going on here?
I think it's about individuality in each county. We found out during tech lead collaborations that we couldn't agree on different things because those different aspects were not going to meet the goals of the individual county organizations. Each county had an approved state plan to meet a specific population of focus. So we couldn't do a one-fits-all type of approach. So we had to do individual type of implementations.
Great, thanks. Well, we're just about at time, so I just want to thank the panelists for all the just really wonderful presentations and all the really just challenging but really important work that's going on as part of this project. And just want to also note, as in the chat, that you can also go to the discussion forum on each presentation, and the presentations will be available to watch until the end of November. So thanks so much for attending the presentation. Thanks for attending TIPS. I hope you guys had a good conference, and yeah, thanks for your interest.
Thank you.
Thanks, everyone.
Bye.
Thank you so much.
Thanks, everyone.